I'm David Jones. I'm a consultant ophthalmologist or eye doctor, and this is a short video about cataracts. At the end of this video, you should be able to adequately assess your patient for symptoms of cataract, including taking a full functional visual history, and be able to counsel your patient as to whether cataract surgery is right for them or not. Most of us are aware of what a cataract is, but most of our patients will be diagnosed by their optician in the first instance. It is incumbent on us as eye doctors to adequately assess the patient to make sure that they really need cataract surgery. The definition of a cataract, of course, is beyond doubt. It's an opacification of the lens. The problem here, of course, is that opacification is open to interpretation, as is the degree of impairment. So I'm going to tell you about how to quantify these for the purposes of assessing your own individual patient. The causes of cataract are very long and pretty much irrelevant to today's management, because if you've got a cataract that troubles you, you just need the surgery. There are really only two questions you need to ask of your patient who is thought to have cataract. The first is very straightforward. Are you bothered by poor eyesight? The second is, do you drive? Because if a patient is not bothered by poor eyesight and does not drive, they do not need cataract surgery, almost certainly. So if the answer to the first question is they aren't bothered, they're almost certainly going to leave your hospital without needing cataract surgery. If, however, your patient is troubled by poor eyesight, then we have to ask a series of functional visual questions. I suggest that you start with the near vision functional question. Most people's near vision is all about reading, but a lot of our patients are also keen on modelling, crafting, and needlework. The next question you ask is about distance visual function. And for most people, their most important distance visual function is about watching the television. Other people, of course, need to drive, but we'll come across that later. Next, you should ask about the symptoms of glare. That's where the vision rapidly gets worse when oncoming headlights or low setting sun or rising sun. And finally, some of our patients can see to read and have good distance vision, but are very embarrassed that they are unable to recognise familiar faces at distance. And this would be a soft indication for recommending cataract surgery. If a patient is not troubled by poor vision, but they drive a car, then we must make sure that they are legal to drive a car. The DVLA and the national law dictates that a patient must be able to read a car number plate with both eyes open at 20 metres with their distance glasses on. It also dictates that a patient must be able to see 6/12 on a Snellen chart, either with one eye or both eyes with their glasses on. Although an optician will probably already have examined your patient for cataract, as non-ophthalmologists, we should at least recheck the visual acuity, not least to make sure that the patient is legal to drive, but also because a lot of health commissioners in the United Kingdom these days will not pay for cataract surgery in patients who have a visual acuity of better than 6/12. So there we see 6/12 is an important cutoff, but is not really the main indication for cataract surgery. We could also, if we wanted to, get out our monocular direct ophthalmoscopes and examine the red reflex. This is an example of a spoke-like cataract against the red reflex of a dilated pupil. If we are able to perform slit lamp biomicroscopy, then we would look at the cataract in a bit more detail. We would look at the front of the lens, and you can see that here is a large and thick shadow against the red reflex, but it's at the front of the lens. The front of the lens is optically very insignificant when it comes to diffraction and visual impairment, and so that doesn't really impress us. Whereas nuclear opacities are a browning of the centre of the lens, which can creep up very slowly on patients before they finally decompensate and develop impairment. In fact, the most visually significant aspect of cataracts is the posterior subcapsular cataract, such as this one shown here. It looks quite subtle, but is visually very disabling because it causes impairment of reading and glare. We as doctors can cause posterior subcapsular opacities by exogenous steroid administration and irradiation. Finally, we are obliged to look for other causes of vision impairment other than cataracts. It's very easy just to diagnose a patient's vision impairment as being due to cataract because everybody over the age of 70 has some opacification of their lens, but it is not necessarily the reason for the impairment. The benefits of surgery are pretty obvious. A patient will almost certainly have clearer vision and will be able to maintain their driving career, and these are the two main reasons for recommending surgery. As an added bonus, our patients get to have a reduced dependency on glasses for distance vision, whether they are long-sighted or short-sighted, because they will also be able to, we are also able to put a lens implant inside the eye to compensate for the patient's previous long and short-sightedness. It is equally important for us to discuss the risks of cataract surgery. And the most feared risk for cataract surgeons is the postoperative endophthalmitis, as shown in the picture here. Although it only occurs in one in about 2,000 or 3,000 operations, it is absolutely devastating because a patient may well not ever see out of that eye again. And if we do not mention it at the first point of assessment, then the patient may go into cataract surgery believing that it is straightforward as, for instance, getting their nails done in a nail bar, which it certainly is not. The other risk that we need to discuss with our patients is the risk of ruptured capsule. As cataract surgeons, we are attempting to remove the cloudy lens from a basement membrane that is really only about 1/10 of 1 millimetre thick. So it is somewhat surprising that only 1% of such operations result in a ruptured capsule. If the cataract is not yet out of the capsule by the time the rupture occurs, then, as seen on this picture here, the cataract can start falling through that rupture into the back of the eye. This is a devastating complication which is at least rectifiable, but requires further surgery by a different surgeon on a different day, and may well lead both the surgeon and the patient to regret ever having entered into the venture in the first place. It is getting increasingly difficult, actually, to advise against intervention, particularly with cataract surgery these days, because we're somewhat the victims of our own success. But I have found these phrases as helpful to both the doctor and patient so that we can leave without treatment, but with a satisfying result. For those patients that do end up having cataract surgery, it's a relatively straightforward procedure. They undergo a procedure which only lasts about 15 minutes on average. The patient is usually wide awake and their eye is numb just with eye drops alone. It does require them to keep their eyes in one position, but it's surprisingly straightforward. And all the patient needs to do is put eye drops in the eye for 4 weeks after the surgery. They can walk off the operating table and can walk out the hospital within a matter of minutes of their surgery, and can carry on with the rest of their lives within a matter of hours. The vision tends to return within about a day or two. Cataract surgery in children is also possible. It is more clinically urgent because of the risk of amblyopia. It's also risky because we can cause glaucoma. It is technically more demanding because the tissues are much more elastic. But patients will usually get a lens implant. But because of the technicalities of the surgery, most of these children need a stitch. So in summary then, it is incumbent on us as doctors not just to rubber stamp a recommendation from the patient's optician, but to take a proper history to make sure that your patient is indeed bothered before we start recommending them for surgery. We should also consider our duties as doctors to ensure that our patients are not driving illegally. we should not be afraid to counsel our patients about the specific risks of infection and ruptured capsule. We should be prepared and brave enough to advise against surgery, thereby complying with our obligation to first do no harm. If we select the right patient for the right surgery, then our patients are usually not waiting too long for surgery behind a queue of unnecessary operations, and we can often end up with a mutually very beneficial and satisfying result, such as the one shown here. Thank you for your attention.